Hi class, it's me, Dr. Jenkins, and in this module we're going to be talking about hematuria. Here are the learning objectives. We're going to talk about differential diagnosis for hematuria and a systematic approach to evaluating patients with hematuria. We're going to talk about the significance of dysmorphic hematuria, and we're going to talk about the difference between urine dipstick and microscopy. And we're going to go through the pathogenesis, risk factors, clinical presentation, and the diagnosis and management of UTIs, nephrolithiasis, bladder cancer, and nephritic syndromes. So the differential diagnosis for hematuria is usually divided up into glomerular causes and non-glomerular causes. And glomerular causes are going to be mostly glomerulonephritis, and that has its own big differential diagnosis that we'll talk about later. And your non-glomerular causes of hematuria are usually involving somewhere in the urinary tract. And we're going to talk about these four causes because they are the most common. So the first step, if you have a patient who says there's blood in their urine, is to confirm that there actually is blood in their urine. And so typically you're going to do that with a urine dipstick, which is going to detect heme in the urine. So that can be positive if they have hemolysis or rhabdomyolysis, because there will be hemoglobin or myoglobin in the urine. And so if you do have a positive dipstick, the next step is to get urine microscopy so that you can confirm that there actually are red blood cells. If you have normal red blood cells in the urine, it suggests non-glomerular origin somewhere in the urinary tract. There's bleeding. If there are dysmorphic red blood cells, it suggests that there is glomerular disease. There's some kind of damage to the glomerulus that's allowing blood to leak out. So these are just some examples of urine microscopy. On the left, you see what normal red blood cells look like, just nice, round, normal cells. And on the right, you see dysmorphic red blood cells. They're not nice and round, and they have these extra blebs on them as they're injured, passing through the glomerular filter. And so sometimes they're called acanthocytes as well, but you're just looking for abnormal shapes and blebs. Sometimes they look like Mickey Mouse ears. All right, here is a nice diagram that kind of shows you the systematic approach to evaluating hematuria. It's from the New England Journal of Medicine. Sorry that the text is so small, but the first step, like we talked about, is getting your dipstick. The next step is getting your analysis with microscopy and a basic metabolic panel so you can evaluate what their GFR is. If it's dysmorphic red cells, like on the left, you're going to do a glomerular workup. And if it's non-dysmorphic red cells on the right, you're thinking this is non-glomerular bleeding. And the first thing that you want to evaluate for in that case would be like a urinary tract infection, because that's the most common cause. Urinary tract infections are divided up into cystitis, which is a bladder infection, pyelonephritis, which involves the kidneys, and also prostatitis. So urinary tract infections are caused by bacteria that have colonized their urethra or periurethral space that have then migrated into the bladder, and then they can ascend into the urinary tract, and that causes an inflammatory response. Rarely you can have bacteria in the bloodstream like Staphylococcus aureus that migrates to the kidneys or bladder, but that is much less common. Most of the bacteria that we're dealing with are coming from the GI tract, so there are these Enterobacterales species, and E. coli is by far the most common bacteria in urinary tract infections. But you might also see Klebsiella pneumonia and Proteus and other pathogens from the GI tract. And then you also see gram-positive cocci like Enterococcus, which also comes from the GI tract, Staphylococcus saprophyticus, and sometimes you'll see group B Streptococcus. Risk factors for urinary tract infection include female sex, because the urethra is shorter, so it's easier for bacteria to get into the bladder, sexual intercourse, and in postmenopausal women, atrophic vaginitis. Diabetes mellitus is also a big risk factor for UTIs, in part because it causes some immunocompromise and also because of the excess glucose in the urine. Immunosuppression, so people who are like on medications for organ transplant or autoimmune conditions have a higher risk of urinary tract infection. And then people with functional or structural urologic abnormalities, like, say, neurogenic bladder, were not able to empty their bladder normally, or if they have congenital abnormalities, those can increase your risk of urinary tract infections. And then people with chronic indwelling urinary catheters, having a foreign body there is a huge risk factor for UTI. So the clinical presentation for cystitis or bladder infection is typically going to be irritative, voiding symptoms like dysuria or pain with urination, urgency, the feeling that they need to go right now, and frequency, peeing more often. They may also have suprapubic pain and hematuria. It's important to note, too, though, that they shouldn't have any urethral discharge. If they are having that, you may consider other things like urethritis, sexually transmitted infections. Pyelonephritis is a kidney infection, so you're going to have more systemic symptoms like fever, chills, and rigors, nausea and vomiting, and they'll commonly also have flank pain or abdominal pain. So for diagnosis of urinary tract infection, typically you're going to get a urine dipstick. You're going to look for the leukocyte esterase, which is an enzyme that is released by white blood cells when they're lysed. If you have a negative leukocyte esterase on a urine dipstick, urinary tract infection's pretty unlikely. You also look for nitrite, so gram-negative bacteria can reduce nitrate to nitrite. So if you see nitrite in the urine, then it's possible that there's gram-negative bacteria there. This would be gram-negatives like E. coli, Klebsiella, Enterobacter. But you're not going to see this if they have gram-positive cocci like Staph saprophyticus, or if they have Pseudomonas, which is an important gram-negative bacteria to be aware of. Also, if they've been taking an over-the-counter urinary analgesic like phenazopyridine, that can give you a false positive on the nitrite. If the urine dipstick is positive, you'll get urine microscopy, and this will show if there's white blood cells like pyuria. And so if you have more than 5 white blood cells, that's abnormal. If you don't see any white blood cells, that has a pretty good negative predictive value that they don't have a urinary tract infection. But if they do have white blood cells, that does not clinch the diagnosis. You can have white blood cells in your urine for other reasons, especially if you have like a foreign body indwelling catheter, or if you have like interstitial nephritis. So presence of pyuria does not equal infection. You can also see bacteria on urine microscopy, and you'll get a urine culture. And the gold standard for a urinary tract infection is if they have over 100,000 colony-forming units of bacteria per milliliter in their urine. That is consistent with a urinary tract infection if they have symptoms. Now, not every patient requires urine testing. If you suspect acute, uncomplicated cystitis, like in a young premenopausal, non-pregnant woman, then you can make the diagnosis based on their clinical presentation alone, and you can treat that person with empiric antibiotics. But who does need urine testing? So if they have any signs or symptoms of kidney infection or more systemic illness or sepsis, you definitely want to test their urine. If you suspect a complicated urinary tract infection, so the patient is immunosuppressed or immunocompromised, if they have diabetes, or if they have known functional or structural urologic abnormalities, you should test their urine. If they have a high risk of multi-drug resistant organisms, like prior resistant organisms or recent hospital stay or recent antibiotic use, you should test their urine. Or if you start someone on antibiotics empirically and they're not getting better after 48 hours, you should test their urine. Now, just because a patient has positive urine testing, it does not mean they necessarily have a urinary tract infection. A patient has to have signs or symptoms of infection to diagnose a UTI. Asymptomatic bacteriuria is pretty common, so you can just have bacteria in your bladder that's not causing symptoms. That usually represents colonization, and it's pretty prevalent in older patients, especially older women, and in patients who live in nursing homes. And we know that if you treat those patients with antibiotics, you're exposing them to the risk of adverse effects from those antibiotics, like C. diff colitis, and also you're going to increase antimicrobial resistance. And so the guidelines recommend not treating patients with asymptomatic bacteriuria, except in a couple different situations. So pregnant women, you want to treat them with antibiotics, and patients who are going to have a urologic procedure that could have mucosal trauma and bleeding. You don't want to seed the bloodstream with bacteria, and so those patients should also be treated with antibiotics prior to their procedure. Now, for treatment of cystitis, just a bladder infection, the first line treatment is going to be nitrofurantoin, um, and it's 100 milligrams twice a day for 5 days. You don't want to use this in patients who have poor kidney function because the antibiotic won't be concentrated in the urine if their creatinine clearance is less than 30. But in most patients, for empiric choices of treating cystitis, nitrofurantoin is your first line. You can also use trimethoprim sulfamethoxazole. And if it's a non-pregnant premenopausal woman, you can treat them for 3 days. If they don't fit those categories, then you treat them 5 to 7 days. You want to avoid trimethoprim sulfamethoxazole if they've had previous exposure in the last 3 months, or if you know that local resistance rates to Enterobacterales like E. coli exceeds 20%. So here in Utah, E. coli's susceptibility to this drug is only 73%, so it's probably not your best empiric option. But if you have a urine culture that shows it's sensitive, then you're good to use this one. You can also use beta-lactams like cephalexin, cefuroxime, or amoxicillin clavulanic acid, and typically you're going to do 5 to 7 days if you use a beta-lactam. The guidelines also recommend using fosfomycin, which is a single dose of 3 grams, but this may not be as effective as the other options, and we typically try to reserve fosfomycin for strange resistant organisms, so generally we don't use this as a first-line option. Fluoroquinolones are not recommended as a first-line option just because of the side effects and they have increasing resistance, but they are excellent for pyelonephritis. So if you have a patient that you suspect pyelonephritis, then maybe fluoroquinolone would be appropriate. So for treatment of pyelonephritis, typically these patients are sicker. And so especially if you're admitting them to the hospital or if they have signs of sepsis, you're going to want to use IV antibiotics up front. So first choice is typically ceftriaxone, a third-generation cephalosporin. If they have a life-threatening beta-lactam allergy, then you can use aztreonam, which is a special monobactam beta-lactam that doesn't have any cross-reactivity with other beta-lactams for hypersensitivity reactions, but it really only kills gram-negative infections. So you have to be fairly certain that that's what you're dealing with. If they have risk factors for Pseudomonas, then you're going to want to use something that will cover that, like piperacillin tazobactam or cefepime. And if they have a history of organisms that produce extended spectrum beta-lactamase, also called ESBL, then you're going to want to use a carbapenem like meropenem as your empiric treatment. Now, after you have urine culture and susceptibilities, your first choice would probably be trimethoprim sulfamethoxazole for 7 to 10 days. 7 days if they get better quickly, 10 days if they kind of have a delayed response of improvement. You can also use beta-lactams if they're sensitive. That would be for 7 to 10 days. And then, if those aren't options for the bacteria, then you're going to use levofloxacin or ciprofloxacin, both fluoroquinolones, for 7 to 10 days. And sometimes you get, a bacteria that's not sensitive to any of those things, and you have to give the patient IV antibiotics for the full course. And it's important that you never use nitrofurantoin or fosfomycin for pyelonephritis because you don't get good enough tissue concentration in the kidney. These are really just used for cystitis. Now, catheter-associated urinary tract infection is an important type of UTI to be aware of. This is something that's tracked as a quality metric for hospitals. And so the CDC definition is if you've had an indwelling catheter for more than 2 consecutive days with a positive urine culture, with the presence of fever or any of these other symptoms of urinary tract infection, that's how you diagnose a catheter-associated UTI. And the treatment is that you want to discontinue the catheter if possible. If the patient still needs one, then you're going to exchange the catheter and get them a new one. You want to get a fresh culture from the new catheter to confirm the organism that you're dealing with. And typically, you're going to treat them for just 7 days. Some patients may require a longer course. Now, prostatitis is something that you should think about anytime you have a male with a urinary tract infection. It's going to present with the same symptoms: dysuria, voiding symptoms. They are more likely to have systemic symptoms like fevers, chills, and rigors. And so, anytime you have a male with a urinary tract infection without a good explanation, like they don't have an indwelling catheter or something, you want to check their prostate, palpate the prostate to see if it's tender, to see if it's swollen or hot. And that's typically how you would diagnose prostatitis is based off clinical symptoms and clinical exam. Now, if you're concerned about, a prostatic abscess, which is a rare complication of prostatitis, you can get imaging to look for that. But typically, you're going to treat these folks with 2 to 4 weeks of antibiotics tailored to your urine culture, and your top choices are going to be trimethoprim sulfamethoxazole or fluoroquinolones if the bacteria is susceptible to those. Now, many patients will have recurrent urinary tract infections, so it's also important to think about UTI prevention. And so, there's some things that are recommended that maybe don't have the best evidence, but they're pretty easy and harmless to do. So, things like voiding immediately after sexual intercourse is probably a good idea. Increasing your hydration so that you're peeing more frequently and not having urine stasis in the bladder. Neither of those things are proven to reduce urinary tract infections, but they make sense, so generally they're recommended. If you have a postmenopausal woman with atrophic vaginitis with recurrent urinary tract infections, there's very good evidence that vaginal estrogen can help reduce urinary tract infections, so that's something you should definitely recommend. Cranberry extract is something that many patients will try. There's pretty mixed evidence on that, but again, low risk of harm, and so if patients want to try that, that's probably okay. There's another drug called methenamine, which is actually converted to formaldehyde in the bladder. There's recent randomized controlled trials that shows that these also reduce the risk of urinary tract infections, so that's a pretty good option if someone has recurrent UTIs. Some patients will use antibiotics prophylactically after sexual intercourse, and then some patients will also try continuous antibiotic prophylaxis, which is effective at reducing recurrent UTIs. But you can imagine if you're taking an antibiotic all the time, you're going to end up with a much worse antimicrobial resistance. And so when those patients do get a urinary tract infection, it's no longer susceptible to the antibiotic that they've been taking. And so typically this is something you would only consider doing, in consultation with like an infectious disease specialist or a urologist. Okay, so we've talked about urinary tract infections. If you evaluate your patient with hematuria and they don't have signs or symptoms of urinary tract infection, you should also be thinking about nephrolithiasis. Nephrolithiasis affects 1 in 11 people in the United States, so it's a very common condition. By age 70, about 20% of men have had a kidney stone and 9% of women have had one. It's much more common in white patients, and it is associated with an increased risk of chronic kidney disease and cardiovascular disease. So kidney stones develop when you have supersaturation of urinary solutes that are able to precipitate and form these crystalline materials. Typically, that's going to happen when you have low urine volume because that increases the concentration of the solutes, or if you have abnormal urine pH, which can modify the solubility of solutes. And then if you have low urinary citrate is going to inhibit crystallization by sequestering calcium, so patients with low urinary citrate will have more stones. Now, you can have supersaturated urinary solutes and not develop stones. Typically, you need a nucleus for those solutes to form a crystallon, and so that can be like an injured epithelial cell, or you can have calcium phosphate plaques in the glomerular basement membrane that can form that nucleus. The most common stones are calcium oxalate stones, and calcium phosphate are also fairly common. But you can have other stones too, like uric acid stones, struvite, and cystine, which are important causes of kidney stone, just not as common. So risk factors for all types of kidney stones include low urine volume because you're going to have an increased concentration of your solutes. This could be from inadequate intake, you're just not drinking enough, or it could be because you're losing water. So patients with chronic diarrhea have an increased risk of kidney stones. Also patients with lots of sweating, so if you come from a really hot climate, that can increase your risk of kidney stones. And then there's pretty good evidence that obesity, metabolic syndrome, and diabetes also all increase your risk of kidney stones. Now, calcium oxalate stones are the most common cause of kidney stones, and there's a lot of different risk factors that can increase your risk of calcium oxalate stones. One of them is hypocitraturia. So, if you have low citrate in the urine, the citrate typically is going to sequester calcium, prevent it from combining with oxalate. And so, if you have low citrate, that could predispose you to this. It's typically seen in patients with metabolic acidosis and hypokalemia. Hypercalciuria is probably one of the most common risk factors for calcium oxalate stones. You can have idiopathic hypercalciuria, which is often seen in families. So there's probably a hereditary component to that. Excessive sodium intake will also increase the amount of calcium excreted in the urine. And then primary hyperparathyroidism causes hypercalcemia and also calcium wasting in the urine. Hyperoxaluria, so too much oxalate in the urine can be caused by eating too much of it or fat malabsorption. So people with like Crohn's disease, gastric bypass, cystic fibrosis, they're not absorbing fat. Fat then binds to calcium, and then you have a bunch of oxalic acid that would normally bind to calcium in the gut that gets absorbed into the serum and then excreted in the urine. So you have too much oxalic acid in comparison or relative to calcium. There's also a genetic autosomal recessive disorder called primary hyperoxaluria that could show up like in teens or 20s, and so that's something to think about too if someone has a lot of oxalic acid in their urine. Medullary sponge kidney and polycystic kidney disease also increase your risk for calcium oxalate stones. Calcium phosphate stones typically form when you have an alkaline urine, and so someone with like a distal renal tubular acidosis, like a type 1 RTA, like from Sjogren's syndrome, they can get calcium phosphate stones. Patients who are on medications that inhibit carbonic anhydrase, like acetazolamide, they're going to have too much bicarbonate in their urine, which is going to keep the pH high. They can get calcium phosphate stones as well. And then the other things that increase your risk of kidney stones, like low urine volume, low urine citrate, and hypercalciuria, can increase calcium phosphate stones. Then there's your non-calcium stones like struvite. So struvite is magnesium, ammonium phosphate. And these also form in an alkaline urine pH. And so typically you're going to see these in folks who have a urease expressing bacteria. These they split urea into ammonia, which is going to make your urine more alkaline. The most common causes are going to be Proteus, Klebsiella, and Staphylococcus saprophyticus. Cystine stones are caused by an autosomal recessive genetic disorder called cystinuria, and they tend to form in a low urine pH. And then uric acid stones also form in a low urine pH. You'll often see these in folks with a metabolic acidosis because there's more hydrogen protons that need to be excreted by the kidneys, and so that's going to lower your urine pH. You also see it in people who just make a lot of uric acid and have a lot of uric acid in their urine, and that can be seen in people with like a high cell turnover, like a myeloproliferative disorder, or someone with like leukemia. Especially after you start chemotherapy and you have tumor lysis syndrome, you're going to have a lot more uric acid in the serum and in the urine. So clinical presentation for kidney stones is often going to be an abrupt onset of severe pain, usually in the flank, but can radiate down into the groin. And it's paroxysmal and colicky, kind of coming and going, but it's really severe, and frequently you'll see patients, they just can't stop moving and wiggling as they're trying to get comfortable. Frequently you're going to see hematuria, either gross or microscopic, and they may have other irritative voiding symptoms like dysuria, urgency, frequency, and nausea and vomiting. So to diagnose a kidney stone, the best test is a CT scan without contrast. It has very high sensitivity and specificity. It can detect stones that are radio-opaque and radiolucent, but they are expensive and they do increase your exposure to radiation. An alternative test would be a renal ultrasound. These don't have very good sensitivity, but they have very good specificities. If you see the stone on the renal ultrasound, that's a pretty good diagnostic test. You're going to use these more in pediatric patients and pregnant patients so you can avoid the radiation. You can also use them to screen for like hydronephrosis. In addition to CT scan, to diagnose the stones, you also want to work up the cause of the stones, so getting a complete metabolic panel, serum uric acid, serum phosphate, vitamin D level, a parathyroid hormone, and urinalysis with microscopy. So your microscopy, if you're lucky, could show you some clues as to the type of kidney stone you're dealing with. So you might see calcium oxalate crystals, which can look like the classic envelope, or they can also be the dumbbell. Both are calcium oxalate. And you might see less common crystals like calcium phosphate, struvite, which are the coffin lids, uric acids, which are diamonds or footballs, and cysteines, which are classically these hexagons. So management of a kidney stone is largely based on the patient's symptoms. If they have signs of like a concomitant infection, which can happen if the kidney stone is colonized with bacteria, you can have a UTI and a kidney stone at the same time. Those patients require an urgent urology evaluation because they might need, like a stent to try to drain the pus. Or if they just have like uncontrolled pain, nausea, vomiting, they may require admission just to control those, to stay hydrated and things. And then the rest of management is based on the size of the stone. So if it's a small stone, then there's a pretty good chance that the patient's going to pass it on their own. So you're just going to hydrate them, you're going to treat their pain, and you're going to have them strain their urine to try to collect the stone. If the stone is between 5 to 10 millimeters, they still have a 50-50 chance of passing that stone. And so you're going to start typically with supportive care, hydration, and you might put them on like an alpha blocker, like tamsulosin, to help pass that stone. And then if the stone is more than 10 millimeters, they have a pretty low chance of actually passing the stone on their own. So that's when you definitely want to get urology involved because they may need a more surgical management. So again, management is mostly supportive care up front. You want to control their pain. Ketorolac is a nonsteroidal anti-inflammatory that you can give IV. That's really great for kidney stone type pain. But they may also need IV opioids like morphine or hydromorphone. IV fluids are a cornerstone in management. You want to make sure they're very well hydrated. And then we'll use alpha blockers like tamsulosin in both men and women. So typically, these drugs are used in people with benign prostatic hypertrophy, but you can also use them in kidney stones. It's thought that they probably act on the smooth muscle of the ureter as well to help relax that, so you're not having that constant constriction against the stone. Strain urine. It's important if you can collect the kidney stone to actually do a formal analysis of the type of stone you're dealing with. And then, like we talked about, if the stone is more than 10 millimeters, you want to consult urology. So once you've dealt with the kidney stone, you want to prevent the patient from getting more kidney stones in the future. Most patients will have recurrent kidney stones, and so it is important to think about prevention. One thing you should recommend for all patients is to increase their urine volume to at least 2.5 liters a day. So that means they're going to have to be drinking at least 2.5 liters per day. You also want to cut their sodium intake if possible, because excessive sodium intake does decrease how much calcium is absorbed in the proximal tubule. And then once they're at a steady state in the outpatient setting under normal conditions, you want to do a 24-hour urine collection so that you can see how much calcium, how much phosphorus, how much uric acid, and all of those things are in the urine. And you can check supersaturation things. And based on that, you may recommend different treatments. So if they have hypercalciuria, you may recommend a thiazide diuretic to decrease how much calcium is getting into their urine. If they have hypocitraturia, so low urine citrate, or if they have uric acid and kidney or cysteine kidney stones, you may recommend potassium citrate. That citrate is going to sequester urine calcium and inhibit it from crystallizing. You're also going to make their urine pH more alkaline, which is going to reduce your risk of uric acid and cysteine stones. If they have hyperoxaluria, then you may put them on some calcium citrate. That calcium can bind the oxalic acid in the gut and prevent it from being absorbed. And if you find that they're making way too much uric acid and there's a lot of uric acid in their urine, you may put them on allopurinol to reduce that. All right, so if you've evaluated your patient with non-glomerular bleeding for UTI and kidney stones and they don't have any signs of either of those, you do need to worry about cancer. Urothelial carcinoma, overall lifetime risk is low, 1.1% in men, 0.27% in women. But worldwide, there's 1.6 million cases, and there's about 80,000 new cases a year in the US, 17,000 deaths per year. Your risk factor for urothelial carcinoma are the biggest risk factors are age and smoking. And so age over 40 years, the median diagnosis is 70, but anyone over 40 should be checked for this if they have hematuria. Male sex, males are more likely to have bladder cancer than women, and then smoking, about 50% of bladder cancer is in smokers. But family history is also important, especially if they have like Lynch syndrome, if they've ever had radiation to their pelvis or prior chemotherapy with like cyclophosphamide, that increases your risk of bladder cancer. And then prolonged exposure to an indwelling catheter or chronic urinary tract infections, that irritation can cause, can lead to cancer. And then there's some classic industrial toxins you should be aware of, like benzene, aromatic amines, aniline dyes, and arsenic. If your patient has exposure to those things, that would be a big risk factor. And then in Africa and Middle East, schistosomiasis infection is one of the leading risk factors for bladder cancer. So the pathogenesis of bladder cancer, typically you're going to have some kind of carcinogen like tobacco use, plus an age-related reduction in your ability to repair DNA. So this is typically something you see in older people. If you look at the actual urothelial carcinoma genetic makeup, they typically have mutations in ERBB2, P53, and retinoblastoma 1. And your urothelial cells line the bladder, but they also line the upper urinary tract, including the renal pelvis and ureters, and the proximal urethra. So you can actually have urothelial carcinoma in any of those areas, but 95% of it is going to be in the bladder. And when you diagnose this, you're going to classify it based on whether it's invasive or not. So if it's not invasive in the muscle, it can be isolated to the urothelium or the lamina propria. That's going to be managed differently than cancer that is invasive in the muscle and beyond. So the typical clinical presentation for bladder cancer is painless gross hematuria. And so in some studies, 16.5% of patients with gross hematuria have bladder cancer. But it can also be picked up in asymptomatic individuals, microscopic hematuria. So 4% of patients with microscopic hematuria have bladder cancer. And it may show up with dysuria, urgency, and frequency. So this is a table from a JAMA review article on bladder cancer. Basically, you're going to risk stratify your patients based on what type of hematuria they have and what risk factors they have. So if they have asymptomatic microscopic hematuria, you still need to evaluate them for potential bladder cancer. So you're going to do that by risk stratifying them. If they're low risk, you can probably just repeat a urinalysis in 6 months. But based on the decision making with the patient, they may opt for a more aggressive investigation. If they're intermediate or high risk, then they do require cystoscopy and some kind of imaging. All patients with gross hematuria should have cystoscopy and imaging, though. And so here's another table that shows, for your microscopic hematuria, this is how you're going to risk stratify these patients. So low risk patients are going to be women less than 50, men less than 40, never smokers or not very much smoking, and if they don't have a lot of red blood cells on their analysis, that's going to be your low risk patients. Versus the other side, high risk, if you're over the age of 60, if you have 30 pack year smoking history, if you have a lot of red blood cells on your urinalysis, or any prior history of gross hematuria, that puts you in the high risk category. So for diagnosis of bladder cancer, the gold standard is cystoscopy. So you want to actually go in there and take a peek with the camera. And then CT urography with and without contrast. So this is recommended for all patients with high-risk microscopic hematuria and anyone with gross hematuria. And this has very high sensitivity and specificity for finding bladder cancer, and it can look at the kidneys as well to identify like a renal cell carcinoma. Renal ultrasound is less sensitive, but you can use it in folks with low to intermediate risk microscopic hematuria and people who want to avoid radiation. And then cytology can be done. You can actually, send urine samples for cytology. It has pretty poor sensitivity, 37%. But if you do have abnormal cells present, the specificity is excellent. So for your non-muscle invasive bladder cancers, they have pretty good outcomes. You're going to do superficial or minimally invasive resection of the tumor at the time of cystoscopy. And some patients, based on risk factors or the results of that initial resection, they may have to go back for an additional transurethral resection in 4 to 6 weeks to evaluate for residual disease. But if they have low or intermediate risk disease based on their pathology, you're going to do a dose of intravesical chemotherapy. So you're actually going to instill a chemotherapy into the bladder. If they have higher risk features, then you're actually going to instill the BCG, which is a live attenuated form of Mycobacterium bovis. You're going to instill that into the bladder, and that activates an immune response against the cancer cells and is very effective for preventing recurrence. If they have invasive bladder cancer, you're going to typically require surgical resection for if they have non-metastatic disease. So that could be a partial cystectomy or a radical cystectomy with lymph node dissection and urinary diversion. All of these patients are going to require a cisplatin-based chemotherapy. So if they have non-metastatic disease, you're going to give a neoadjuvant cisplatin before cystectomy. If they have metastatic disease, and this is going to be your primary treatment. Some patients will also receive immunotherapy for metastatic disease, especially if their cancer tumor expresses PD-L1. You can use like pembrolizumab or some of the other checkpoint inhibitors. Okay, so we've talked about common causes of non-glomerular bleeding. Now let's talk about what you do if you see a patient with dysmorphic red cells and you're worried about a glomerular cause. Now, when you have a patient with glomerular hematuria, you want to look to see if they have a nephritic syndrome. So that's going to be categorized by dysmorphic hematuria, some proteinuria, usually less than 3.5 grams, because this is not nephrotic syndrome. And usually they're going to have hypertension and an acute kidney injury. If you see all of those things, then you're going to be looking for a glomerulonephritis. If they just have dysmorphic hematuria and they don't have those other problems, then you might consider other things like Alport syndrome or thin basement membrane disease, which is often familial and has an excellent prognosis. They basically just have abnormal type 4 collagen, which leads to the dysmorphic hematuria, but they don't have progression to end-stage kidney disease usually. Nephritic syndromes have a pretty big differential diagnosis, and we divide them up into these broad categories: immune complex disease, anti-GBM disease, ANCA vasculitis, and thrombotic microangiopathies. And in your immune complex diseases, the most common by far is IgA nephropathy, and this is your most common primary glomerulonephritis worldwide. Lupus nephritis is also pretty common, and then your classic infection-associated glomerulonephritis, which was formerly called post-streptococcal glomerulonephritis. Less common you'll see are these C3 glomerulopathies like dense deposit disease and cryoglobulinemia. So when you're doing your diagnostic evaluation of nephritic syndrome, you want to get a good history. Have they had any recent or do they have a current infection? You're especially worried about sore throats, upper respiratory infections, GI infections. Do they have any hemoptysis or sinusitis that might make you think that this is like a renal pulmonary syndrome, like an ANCA vasculitis or anti-GBM disease? Do they have any arthritis, rashes, or history of autoimmune diseases that would make you think of lupus or a vasculitis? And do they have any family history of hematuria that might make you think this is more of like an Alport's disease? Exam, you're looking for hypertension, especially in an acute nephritis, and then any signs of comorbid disease like lupus, cirrhosis, or endocarditis. And skin findings like purpura you could see in like an IgA disease or vasculitis. Now, all patients who have dysmorphic hematuria should have a complete metabolic panel and complete blood count, as well as your analysis with microscopy and check a urine protein level. But you're also going to want to do serologic testing for different types of nephritic syndrome. So you can grab an ANA and a double-stranded DNA and complement levels to evaluate, is this lupus or some kind of C3 glomerulopathy? You can get SPEP and serum light chains to rule out myeloma, which doesn't usually present with nephritic syndrome, but it can cause proteinuria, and you wouldn't want to miss that. So most nephrologists will check for that. You're going to send your ANCA and anti-GBM antibodies to look for vasculitis. And then the ASO is your anti-streptolysin O titer, which can be a sign of prior or recent strep infection. HCV and HBV, HIV are also associated with different glomerulonephritis. And then cryoglobulins and rheumatoid factor. Specifically, you're checking for cryoglobulinemia. Now, depending on the type of nephritic syndrome, you'll also probably get a kidney biopsy in most of these cases. IgA nephropathy is the most common cause of primary glomerulonephritis worldwide. It's more common in Asian and white people, and about 50% will go on to develop end-stage kidney disease, so it is a pretty significant problem. IgA nephropathy is caused by deposition of IgA antibodies in the glomerular mesangium, and it's usually going to occur 12 to 72 hours after an upper respiratory infection. It presents with gross hematuria, but you could also detect this with microscopic hematuria in asymptomatic individuals. Now, IgA nephropathy can be primary, but it can also be secondary to other problems like staph infections, cirrhosis, celiac disease, HIV, Crohn's, cystic fibrosis, and psoriasis. So it's important to be aware of your patient's past medical history when you're evaluating them for this. So for IgA nephropathy, if someone has dysmorphic hematuria, the first thing is to see how much protein they have in their urine. If they don't have any proteinuria or hypertension and they have a normal GFR, then that person does not need an urgent kidney biopsy, and you can actually do periodic monitoring just by watching their GFR and checking urine protein levels at regular intervals. If they do have proteinuria, or they develop proteinuria, or they have a drop in their GFR, or they develop hypertension, at that point you do want to get a kidney biopsy so that you can establish the diagnosis and figure out how severe it is. And on your kidney biopsy, you're gonna see IgA light up on the immunofluorescence with the mesangial deposition pattern. Once you've established the diagnosis of IgA nephropathy, the initial treatment is focused mostly on reducing proteinuria, and so the first-line agents for that are ACE inhibitors and angiotensin receptor blockers, which have the added benefit of also controlling their blood pressure. There's also good evidence that SGLT2 inhibitors are effective in IgA nephropathy for reducing proteinuria and slowing down progression of disease. And there's a new FDA-approved drug called sparsentan, which is an endothelin receptor antagonist specifically designed to reduce proteinuria. If you're having severe or progressive disease, often that's when immunosuppression is considered. Historically, that meant like long courses of corticosteroids like prednisone. However, that's often not recommended because of side effects and the risk of infection, so it really depends on the patient. There is a new FDA-approved targeted release budesonide that may be safer, that people are using more for IgA nephropathy. But you may also use steroid-sparing drugs like cyclophosphamide, azathioprine, and mycophenolate mofetil, but those have had mixed results in clinical trials. There's novel therapies that are under development, including like B-cell depleters like CD19 antibodies. And then if they do develop end-stage renal disease, they can get kidney transplantation. Unfortunately, with IgA nephropathy, there is a risk of recurrent disease in the donated kidney. All right, next let's talk about infection-associated glomerulonephritis. This is another important nephritic syndrome that you should know about. Usually it occurs 2 to 4 weeks after an upper respiratory or skin infection, but it can actually happen the same time as an infection, and sometimes the infection is not uncovered until the patient presents with glomerulonephritis. Classically due to Streptococcus pyogenes, but it can be due to other strains of strep, as well as staphylococci, gram-negative rods, and other pathogens like even viruses and fungi. The clinical presentation is typically going to be your standard acute nephritis with hematuria, proteinuria, hypertension, acute kidney injury, and frequently edema as well. It can present as a rapidly progressive GN with severe kidney failure. Typically on labs, you're going to have low C3 due to activation of complement. Your C4 can also be low, but not always. And then also you're going to want to look for antibodies for Streptococcus pyogenes, so your ASO, DNase, streptokinase, hyaluronidase, and anti-NAD antibodies may all be positive, even in patients who didn't realize that they had a strep infection. So at least you want to send a few of those. There are panels where you can send all 5. So if you have a child with infection-associated glomerulonephritis and it's a pretty classic or typical picture, you don't need to do a kidney biopsy. If you have adults with this syndrome, you often will do a kidney biopsy because you want to rule out other potential causes of glomerulonephritis that may require urgent treatment. And the treatment for infection-associated GN is supportive care and treating the underlying infection. So supportive care is blood pressure control. If they have a lot of proteinuria, you can use ACE and ARB for that. You can use diuretics if they have a lot of edema. There's really no role for immunosuppression in this case. Most children are going to have a full recovery. Unfortunately, adults often do have residual kidney disease and have a worse prognosis. Okay, in summary, the first step when you see a patient with hematuria is to confirm that they actually have blood in their urine with dipstick and microscopy. If it's dysmorphic hematuria, you're going to pursue a glomerular workup. If it's normal-looking red blood cells, you're going to evaluate for urinary tract infection, kidney stones, and bladder cancer. Okay, well, these are all the learning objectives that we talked about in this talk. Hopefully you feel confident now evaluating a patient with hematuria and kind of what the main differential diagnosis is for that. Thank you for your attention.